Ozempic, Wegovy, Mounjaro, Ribelsus. These are the most talked about medications in the world right now. Celebrities are using them. Social media is full of before and after stories. Pharmacies are running out of stock, and millions of people are asking their doctors, "Can I have this?" But here is what nobody is talking about. Before any patient starts incretin therapy, there is a critical set of assessments, investigations, and conversations that must happen first, and getting this wrong has real consequences. This is MRCPdoc, Internal Medicine Physician. Today, I am going to walk you through exactly what your doctor should assess, measure, and test before starting you on a GLP-1 or GIP receptor agonist. Not because I want to put you off these medications. The evidence behind them is genuinely extraordinary, but because informed patients get better outcomes, and you deserve to understand exactly what is happening to your body. Let's get into it. Part 1. What are incretin therapies? Before we talk about pre-treatment workup, let me quickly explain what these medications actually are, because understanding the mechanism helps you understand why the checks matter. Incretins are hormones produced by your gut in response to food. When you eat, your gut releases these hormones, and they do several remarkable things simultaneously. They signal your pancreas to release insulin, but only when blood sugar is actually high. This is called glucose-dependent insulin secretion, and it is why these medications have a much lower risk of hypoglycemia compared to older diabetes drugs. They suppress glucagon, the hormone that tells your liver to release sugar into the bloodstream. Less glucagon means less unnecessary sugar being released. They slow gastric emptying. Food moves more slowly from your stomach into your intestine. This means glucose enters your bloodstream more gradually after meals, preventing sharp spikes. And crucially, they act on appetite centers in your brain, specifically the hypothalamus, reducing hunger and increasing satiety. This is why significant weight loss occurs. The two main incretin hormones are GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide. The medications we are talking about today mimic or enhance these natural hormones. GLP-1 receptor agonists include semaglutide, sold as Ozempic for diabetes, and Wegovy for obesity, and liraglutide, sold as Victoza and Saxenda. Dual GLP-1 and GIP receptor agonists, the newer and more powerful class, include tirzepatide, sold as Mounjaro for diabetes, and Zepbound for obesity. The clinical trial data behind these medications is remarkable. Semaglutide reduces major cardiovascular events by 26% in high-risk patients. Tirzepatide achieves average weight loss of over 20% of body weight. These are not lifestyle drugs. These are serious medicines with serious evidence. But they are also medicines with contraindications, potential side effects, and specific monitoring requirements, which brings us to the pre-treatment workup. Part 2. Who is a candidate? Before any investigation, your doctor must establish that you are an appropriate candidate. Current approved indications include type 2 diabetes, particularly when additional cardiovascular or weight benefit is desired, or when other agents have not achieved adequate glucose control. Obesity or overweight, defined as BMI of 30 or above, or BMI of 27 or above with at least one weight-related comorbidity such as hypertension, dyslipidemia, obstructive sleep apnea, or cardiovascular disease. Established cardiovascular disease, semaglutide specifically has a cardiovascular outcomes trial showing mortality benefit independent of glucose lowering. Chronic kidney disease with type 2 diabetes, recent evidence supports renal protective effects. These medications are not appropriate for type 1 diabetes, where the mechanism of action is largely irrelevant as insulin-producing cells are absent. Part 3. Absolute contraindications. Before ordering a single test, your doctor must screen for contraindications. These are non-negotiable: personal or family history of medullary thyroid carcinoma. This is the most important contraindication, GLP-1. Receptors are present on thyroid C cells, the cells that produce calcitonin. In rodent studies, GLP-1 agonists cause dose-dependent thyroid C cell tumors. While this has not been demonstrated in humans, the regulatory agencies have mandated that these medications are contraindicated in anyone with personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. Your doctor must ask about this specifically before prescribing. History of pancreatitis. Acute pancreatitis has been reported with GLP-1 receptor agonists. The causality is debated, but the current guidance is to avoid these medications in patients with a history of pancreatitis, particularly chronic pancreatitis or pancreatitis of unknown cause, pregnancy, and breastfeeding. These medications must be stopped at least 2 months before planned conception. They are absolutely contraindicated in pregnancy and breastfeeding. Severe gastroparesis. Since these medications slow gastric emptying, they can significantly worsen pre-existing gastroparesis. This must be assessed and documented. Diabetic retinopathy. With caution. Rapid improvement in blood sugar control, as seen when starting these medications, can temporarily worsen diabetic retinopathy. This is a known phenomenon seen with any intensive glucose lowering. Retinal assessment should be documented before starting. Part 4. The Pretreatment Investigations. Now, the tests. Here is exactly what should be checked before starting incretin therapy and why each one matters. Blood glucose assessment. HbA1c, glycated hemoglobin. This gives your average blood sugar over the previous 2 to 3 months. It establishes the baseline from which we will measure response to treatment. Target on therapy is generally below 53 millimoles per mole or below 7%, though individualized targets apply. Fasting glucose and postprandial glucose, useful for understanding the pattern of glycemic excursions. C-peptide. This test measures how much insulin your pancreas is still producing. It helps distinguish type 1 from type 2 diabetes, which is critical because prescribing a GLP-1 agonist to someone with undiagnosed type 1 diabetes can precipitate diabetic ketoacidosis. Any patient with atypical features, young age of onset, low BMI, rapid progression should have C-peptide measured. GAD antibodies, glutamic acid decarboxylase antibodies. These are markers of autoimmune diabetes. Again, important to rule out before starting therapy. Renal function, eGFR, and creatinine. Renal function determines both the safety and the appropriate choice of agent. Semaglutide can be used across all stages of chronic kidney disease and actually has renoprotective evidence. However, renal function affects the metabolism of concomitant medications, particularly metformin, which should be reviewed if eGFR falls below 30. Urine albumin to creatinine ratio. Microalbuminuria is a marker of early kidney damage and cardiovascular risk. It should be documented at baseline. Liver function. ALT, AST, GGT, bilirubin, albumin, non-alcoholic fatty liver disease, now called metabolic-associated steatotic liver disease, is extremely common in the population being treated with these medications. GLP-1 agonists actually show emerging benefit in fatty liver disease. However, baseline liver function establishes a reference point and screens for significant hepatic impairment which can affect drug metabolism. Thyroid function, TSH, thyroid stimulating hormone. Thyroid disease is common, particularly in women, and can both mimic and complicate metabolic conditions. A baseline TSH should be documented in the context of the thyroid C-cell concerns discussed earlier. Any thyroid nodule or goiter noted on examination warrants further evaluation before starting therapy. Calcitonin, this is debated. Some guidelines recommend baseline calcitonin measurement, others do not. In patients with any thyroid abnormality or family history concerns, calcitonin should be checked. Lipid profile, total cholesterol, LDL, HDL, triglycerides, GLP-1 agonists modestly improve lipid profiles, reducing triglycerides and LDL. A baseline lipid panel establishes the starting point and informs overall cardiovascular risk assessment. Cardiovascular assessment, blood pressure, documented at baseline. These medications modestly lower blood pressure. Important to know the starting point, especially if antihypertensive medication doses may need adjustment. Resting ECG, particularly in patients with known or suspected cardiovascular disease. Cardiovascular risk score, such as the CRISC-3 in the UK or the pooled cohort equations in the US. This informs the overall risk-benefit discussion with the patient. Pancreatic assessment, serum lipase and amylase, baseline pancreatic enzyme levels. While routine baseline measurement is not mandated in all guidelines, any patient with abdominal symptoms, alcohol history, or gallstone disease should have these checked. Lipase elevation after starting therapy requires immediate evaluation. Ophthalmology, diabetic eye screening, retinal photographs. As mentioned, rapid glucose lowering can temporarily worsen diabetic retinopathy. Baseline retinal status must be documented. If significant retinopathy is present, ophthalmology input is needed before starting. Body measurements, weight, BMI, waist circumference. These establish the baseline from which treatment response will be measured. Waist circumference is particularly important as it reflects visceral adiposity, the metabolically active fat that drives cardiovascular risk. Blood pressure, both arms, to detect any significant difference suggesting vascular disease. Part 5. The patient conversation. Beyond investigations, there is a conversation that must happen. Informed consent for these medications is not just a formality. Patients must understand the common side effect, nausea, vomiting, diarrhea, constipation, which are particularly prominent in the first weeks of treatment and are the primary reason for discontinuation. Starting at the lowest dose and titrating slowly significantly reduces their severity. Patients must understand the injection technique if using subcutaneous formulations and the importance of rotating injection sites. Patients must understand the importance of not stopping suddenly if they have diabetes and the plan for dose escalation. Patients with type 2 diabetes on sulfonylureas or insulin must be warned about hypoglycemia risk, not from the GLP-1 agonist itself, but from the combination. Dose reduction of the sulfonylurea or insulin should be considered proactively. Female patients of reproductive age must be counseled on contraception, as reduced efficacy of oral contraceptive pills has been reported due to delayed gastric absorption. Part 6. Monitoring once started. The pretreatment workup does not end the process. Once started, monitoring is essential. At 3 months, HbA1c, renal function, weight, blood pressure, any new symptoms. At 6 months, full metabolic panel, lipid profile, assessment of dose optimization. Annually, full review including HbA1c, renal function, liver function, lipid profile, retinal screening, foot examination if diabetic, cardiovascular risk reassessment. Any new abdominal pain, even mild, must be evaluated, promptly given the pancreatitis signal. Do not dismiss abdominal symptoms in a patient on incretin therapy. The bottom line: GLP-1 and GIP receptor agonists represent one of the most significant advances in metabolic medicine in a generation. The evidence for cardiovascular protection, weight loss, renal protection, and potentially even neurocognitive benefit is growing rapidly. But they are powerful medications, and powerful medications deserve proper assessment. If your doctor is considering starting you on Ozempic, Mounjaro, or any incretin therapy, you now know exactly what should be checked first. You can ask the right questions. You can be an informed participant in your own care. That is what this channel is about. Knowledge is not fear, knowledge is power. If this video helped you, please give it a like. It genuinely helps this channel reach more patients who need this information. Subscribe so you never miss a plain English medical explanation. Drop your questions about GLP-1 medications in the comments. I read every single one. Share this with someone who has just been prescribed Ozempic or Mounjaro and wants to understand it properly. This is MRCPdoc, internal medicine physician, and I'll see you in the next one.